Hi everyone, welcome to a discussion on solo parenting and fertility preservation. I'm Sharon Martin, the CEO of Fertility Network UK, and I'm really pleased to be hosting this conversation today. More and more people are thinking about their options when it comes to having children, whether that's choosing to become a solo parent or wanting to preserve their fertility for the future. And as such, it's an important topic for many. And we're going to be having this conversation today with Dr Julia Kopeika, consultant gynaecologist at Guy's and St Thomas NHS Foundation Trust. Julia is a leading expert in reproductive medicine and fertility preservation, and she's helped many people explore the fertility choices with compassion and clarity. Today we'll be talking about what solo parenting can look like in practice, the options available for fertility preservation, and some of the key things to think about both emotionally and medically. Julia, thank you so much for joining me today. Maybe you can start by telling us a little about your work at Guy's and St Thomas and what you're seeing in terms of people exploring fertility preservation or solo parenting.
Thank you, Sharon. Thank you for your kind introduction, and thank you everyone for watching this interview. So actually, the fertility preservation field is relatively new, but is very, very fast developing field and growing and expanding. So historically, fertility preservation was used for patients, for people who sadly were faced with cancer diagnosis or some other condition where they would require chemotherapy. And in this setting, chemotherapy could potentially have a risk of making them infertile, and therefore they would come and see a reproductive medicine specialist with a view of freezing eggs, or if it was a couple, embryos or sperm. However, in modern practice, there are more and more other fields that are expanding, and this field becomes interesting or relevant for other group of patients. And for example, from a women perspective who may be still single or not in a relationship, whether they are actively by choice not in a relationship, or their life circumstances are still not at the right point of their life. However, they aware of impact of age on the chances of getting pregnant. So this group of people would benefit from freezing eggs, because our ability to have a baby is strongly depends on the age of the eggs. So going back to Sharon, to your question about solo parenting, we could have patients who come into ours and not ready to have a baby yet, but cautious about the deteriorating impact of age on the eggs, and they volunteer to freeze the eggs. Or we could have single patients who come in and they are ready to have baby now, and in that case we could discuss possibility of using the eggs with donor gametes, and that another field that becoming more and more common and prevalent, and actually quite a big proportion of people considering single parenting in modern life.
So you touched on gametes there. I take it you're talking about the difference between, and can you explain that difference between, if I'm a single person, I'm looking at fertility preservation, what's the difference with coming in and getting egg freezing for the future or embryo freezing for the future, and what are the pros and cons of each?
Of course. Yes, it's a very good question, and basically for the benefit of everyone, just to clarify, so the eggs, we call them gametes, so they belong to you only, and usually in the normal menstrual cycle, a woman would release one egg per menstrual cycle. However, with the help of fertility medication, we could try to collect more than one egg in one cycle, and we can freeze them. Okay. However, you could would opt to have this egg fertilized by sperm. So, for example, if you're a couple in heterosexual relationship where you are settled together, but you're not ready to have a baby, you could have options of creating embryos. So this is slightly like one stage, next stage of their reproductive journey, where the eggs fertilized by sperm, and you could freeze the embryos. Or if you're a single parent, want to have also embryo frozen, you could use donor sperm, and you could have embryo freeze with donor sperm. Now, Sharon, your question is very important and very relevant, because looking at history of IVF, what happened originally when the science allowed us to freeze cells, we were very, very good at freezing embryos. So the embryos could survive very well the process of freezing and thawing and had very good survival. And really, that was in practice for many decades now. However, the eggs for a long time was very, very difficult to freeze, and they wouldn't survive very well. And with kind of techniques that were originally used is called slow freezing, maybe 20 to 30% only of eggs were surviving, whereas embryos with the same technique would have 90% survival. So therefore, at the time, in the beginning, the egg freeze wasn't really so common, for understandable reason, because majority of eggs would never make it through the egg freezing thawing process. However, luckily, we have a new technique called vitrification. Well, I'm saying new. The technique was actually discovered in the end of last century, in the late 90s. But anything that you invent in the lab will take some time to come to clinical practice. But their fast freezing vitrification completely changed the story, because their egg survival through vitrification improved to such a high level that modern studies shows that frozen eggs has as good chance of giving a baby as a fresh eggs. That wasn't the case even 10-15 years ago. So to cut story short, the vitrification survival of eggs will be somewhere, depends on the clinic, on the experience, on the numbers of egg freeze. So they do, survival will be somewhere between 80 to 95%. And we have more and more amazing data showing that once the eggs survive, the rest of their job they would usually do is actually quite excellent, the same as with fresh eggs. So if you're a single person and at the point of your life where you're cautious about the age, but you haven't decided yet, you haven't committed that you want to have baby now, historically, some people would say, oh, freeze embryos with donor sperm because it will give you slightly higher survival rate. However, that's not true anymore. Interestingly enough, our HFA, the Human Fertilization and Embryology Association, that monitor the data rigorously through the whole of the country, somewhere in 2018 published data on chance of baby being born from frozen eggs versus frozen embryos. And this report, though it still had relatively small number of cycles, somewhere around the 500, but that report actually showed that at that time, the live birth rate difference was only 3%. So actually, in the current practice, I would say that if you're not committed yet to have a baby and coming for fertility preservation, my personal advice will be to go for eggs, because the survival will be very, very good and the chances will be as high as possible. Now, does freezing eggs or fertilizing eggs with donor sperm has a role? Probably slightly from cost effectiveness, and maybe from the point of view of knowing more accurately your chances of achieving pregnancy. Because remember, the IVF is a journey. It has multiple steps, and at every step of this journey, there will be some drop of numbers. What I'm saying, if, for example, someone had fresh cycle, let's say you collected 10 eggs, not all of the eggs fertilize, then not all fertilized eggs become good embryos. Okay, so actually freezing certain number of eggs, you can't be 100% certain how many of them will result in good quality embryos. And when we say good quality, that means only assessment under a microscope, telling us that this embryo developing in the right way. It doesn't guarantee the baby. Okay, so therefore, for example, if I have one embryo on day 5 of good grade and called blastocyst, my certainty in predicting your chance of successful outcome will be slightly higher than if you had only 5 eggs, because I can't be 100% sure how many of these eggs will result in good embryo. Okay, so but to me, it sometimes could be very confusing, because some people may say, oh, the embryos have better chance of success. No, no, no. If these 5 eggs were meant to give me a nice embryo, they will give me a nice embryo whether I fertilize them now or once I thought. But what can change? Your perception, your prediction can become more accurate when you have the embryo versus eggs. However, because we have more and more data now, we are pretty good at predicting approximately with how many eggs at certain age group you need to achieve at least 1 or 2 good-looking embryos. So we still have predictions, not like we're working in darkness. It just the certainty of prediction goes a bit higher once you go for embryos. However, remember, the problem, for example, if you were a couple in a relationship where you were together, not ready to have a baby, remember, one day if you decided to use these embryos and sadly you split up, unfortunately, that pretty much will be end of that journey, because to use the embryo, it's like a property of 2 of yours, and if one side withdraw the consent, you can never use these embryos. Okay, now if you are a single woman who decided today to have fertility preservation, fertilize your eggs with donor sperm, remember that the life is full of surprises, and maybe 2-3 years later or 1 year later, you meet a person with whom you want to have a baby together. Therefore, having embryos with donor sperm may not necessarily be acceptable in your new relationship. Okay. However, if in this relationship you suddenly at the age where your natural chance of conception is very low, you still have these lovely eggs that you could use with your future partner and do with them together fertilization and have a baby. So that's basically pluses and minuses of freezing eggs versus embryos. But if I didn't manage to confuse you completely, I think I will be leaning towards freezing eggs, because it gives you autonomy, it gives you options. Making eggs into embryos could restrict your options, but may give you slight better prediction of the outcome, but still not guarantee. Better, it doesn't mean that if you have 3 blastocysts, it guarantees a baby. Still, there is always uncertainty with IVF.
So if I'm in my late 30s or early 40s, would you recommend freezing eggs?
Thank you, Sharon. I think what we can do better is to educate our general population better about our fertility. And really what happened, that our quality of eggs deteriorate as we get older. And in ideal scenario, the best chance of fertility outcome will be if you manage to have your eggs frozen under the age of 35. Okay, so that will give you the highest probability. However, of course, sadly, not everyone even thought about it, or not everyone even knew about it, and not everyone had possibly resources to consider that. And we, of course, will have patients, women who come at much older age. And of course, it is possible to freeze eggs at 37 or even at 40. It's just for us to be very, very honest, to explain people what their chances of the positive outcome with this intervention. It also, what's very important, it's the actual number of frozen eggs you manage to have, because anything with assisted reproduction relies on number. So the bigger number we have, the higher chance of positive outcome it will give us. But ironically, as we get older, it's much more difficult to produce big number, but because there will be a decline of the egg numbers as we get older. But sadly, to achieve positive outcome when you're older, you need much bigger number to have higher odds. Okay, so there is a bit of contradiction on this aspect.
So in the UK, if I went through an egg freezing cycle, how long can those eggs be stored for before I decide to come back and actually use them?
Yeah, I think we were very, very delighted with the change of the law in the UK that increased our options, improved our fertility autonomy, because historically anyone could freeze their gametes for maximum 10 years. So, however, now one could store their gametes for up to 55 years. You may say, why do I need 55 years? Well, that law came based on the fact that fertility preservation may be needed for very, very young people. Like I mentioned, for example, 15 years old girl who sadly has leukemia or something like that. Yeah, so they need much longer time. But for non-medical, for elective egg freeze or embryo freeze, we now still allowed to store gametes up to 55 years. However, we just need to have consent resign every 10 years just to check if you still need them. However, one more important thing, Sharon, for people who are listening to us to remember, though you can freeze eggs and keep them for 55 years, however, one needs to be very cautious because yes, younger eggs will have higher chance of giving a baby, but remember, one still need to carry the pregnancy. And sadly, as we get older, the risk of complications with pregnancy goes up. And really, in the UK, majority of clinic probably will not really support treatment after the age of 50. There might be some clinics that may treat up to 52, but remember, it's not only how long you can use keep the eggs, it's also until what age you can actually do something about them with your own body. That's also important to remember.
Thank you, Julia. So in practical terms, if I'm considering egg freezing for the future, what does the process involve? Do I just phone up the clinic, or do you know, from the very initial, what do I do right through the actual process, the medical intervention? Can you just talk me through that process?
Of course. Luckily, with development of IVF that is actually not that old, just under 50 years. However, I believe we've done so much progress in these 50 years, and the whole process in principle is quite safe from medical perspective. But if, for example, you decided to come to us, what timeline you should expect? First of all, you need to have a first appointment where we obviously take very thorough history, check your medical, surgical background, if there are any other important factors that may influence what we do next. We would also perform ultrasound scan to have a look at your personal egg reserve, because we're all different. So we are born with a certain number of eggs, and as we get older, the number goes down. But that drop is very individual. So one person at 35 may have more eggs than another. So the ultrasound scan and blood test that we could organize at the same time would give you some understanding of what's your personal egg reserve. Now, the egg reserve does not predict your natural chances of conception, because sometimes we discover that someone has very low egg reserve. Actually, as long as you have regular cycle, you still have the same chance of getting pregnant with low reserve as with high reserve. However, if we are talking about IVF or egg freeze or embryo freeze, then egg reserve is relevant because it predicts your potential response to stimulation. So, and we would tell you you have normal egg reserve, you would be expected to have that kind of range of eggs from one stimulation. If you have low egg reserve, you may have much less number of eggs physically possible to get out of you. So that's appointment. At that appointment we also talk through the process, explain the risk, and give you some time to digest. We also offer supportive counseling, and it's not charged separately, and anyone who is considering for any fertility intervention is very welcome to have the counseling. And then the actual process, it takes approximately 2 weeks. So we tend to have the start of the treatment in the beginning of menstrual cycle, and in the first 4 days of the menstrual period we would check, we would see you, scan you, confirm all good to go, and then you would be expected to have some injections. So sorry for people who don't like needles. We haven't yet invented follicular stimulating hormone that could be administered without injections, but they are very user friendly, they are very thin, we do very thorough teaching. I mean, quite often sometimes it's scary if you never dealt with it and suddenly you're asked to do self-administration. You're worried that, oh, it may not work, you may not be able to do it correctly, but please be reassured that we will ensure you're doing it correctly and provide with all the resources and support to do that. And then stimulation with injection takes on average around 14 days, 12 to 14 days. So during these 2 weeks of stimulation, you would need, as I said, you come in the beginning of the cycle, and then potentially you may need to come somewhere between day 6 or 10 of stimulation for another scan to assess the development of the follicles. And after that, if your follicles, follicles is little structures in the ovaries that contain the eggs, so we want them to grow to a certain level before we can say we are ready to have egg collection. And basically after day 10, when we scan you and see how they're doing, we potentially can book your egg collection. In some patients, they may need to have another scan. So really, in total, in 2 weeks time, you may need maybe 3 visits for very kind of quick ultrasound scan, so it shouldn't really interfere with your life and doesn't create extra burden. There is actually no any evidence to say that if you come every second day and do blood and scan, it can improve your outcome, because in some centers that not uncommon practice. I can reassure you that actually with 2-3 scans we can get everything we need safely and with a very, very good outcome. So, and then after we committed ourselves for the egg collection, this is a very minor procedure, usually done under deep sedation, where we put you to sleep. It's not a full general anesthetic, as you will be still breathing yourself. However, you're completely not aware of any pain, and you really very well asleep. It's very minor procedure. It's very quick. It probably lasts around 15-20 minutes, and you stay in the hospital afterwards for a couple of hours, and then you can go home yourself. So really, in total, in 2 weeks, you may have 3 visits for scan and 1 visit for egg collection procedure. In terms of the risk, so as you guys know, anything we do in our life, crossing the road has a risk. So any medical intervention has small risks. From stimulation perspective, the main medical risk that sometimes people may not respond to stimulation. That's more likely if someone is older and has very, very low egg reserve, and hopefully these patients are well warned in advance. However, sometimes we seem to have very good count to start, but the response may not be as big as original prediction. Okay, and then the other kind of the flip side of the low response will be high response, and there is condition called ovarian hyperstimulation syndrome that develops only after egg collection, doesn't develop before egg collection, where someone, if they produce quite high number of eggs, they could start accumulating fluid in their tummy and very rarely in the lungs, and they have slightly higher risk of blood clots. So it's called ovarian hyperstimulation syndrome. Luckily, with modern technologies and using different protocols for fertility preservation, the opposite to general population, there are modern protocols with these different drugs reduce the risk of ovarian hyperstimulation by at least 90%, and really the risk of this complication, very luckily in modern fertility preservation practice, is really rare, less than 1%. So, and so even if it happens, it tends to be on the mild scale with minimum intervention, or just asking people to drink fluid, or sometimes we need to give fluid intravenously if something like this developed. The other risk of surgical procedure will be a small risk of bleeding, infection, very small risk of damage to the organs inside. Luckily, all these 3 are extremely rare, especially in healthy population with no complex surgical history or any medical history. And overall, all of these risks are very low. My personal view is that I strongly think that anyone who is going through this process, I think that it's not the medical risk that potentially have the highest burden, but more psychological burden, because sometimes it could be very, for some people who may have some family history of fertility problem or some relationship breakdown, they come with another layer of anxiety and worries, and also we may sometimes get much less number of eggs than one was hoping in one go. So that can create additional emotional burden that we obviously make sure we support and prepare patients, and also our amazing counseling team, they are on standby to help to navigate through the process and have kind of realistic expectation.
Yeah. So a question that's asked a lot, what is the typical cost going to be involved for a single female who wants to go down the route of egg freezing? I mean, what's that likely going to cost for one cycle?
The cost, I mean, the cost is obviously varies between different clinics. So it could vary from, because remember, so you have clinics will put the cost of the cycle, then there will be cost of medication. So you really need to look very careful between different clinics on the cost. You can look at Guy's private website to look at the cost, but it's and I mean, unfortunately, within fertility field, there is a very, very big range of what one could be charged. What I can reassure patients who come into us that we don't have any hidden or add-on costs that suddenly appear. So we have everything included in the original cost, your sedation for anesthesia, vitrification media, and all sorts of things, and blood test if you need. But if you are choosing different places, just make sure you know in advance that the cost could appear nicely, but then you may end up paying the equivalent amount for their blood tests and scans. So we have all inclusive package.
Yeah. So Guy's in St Thomas as an NHS clinic, but it also does private treatment. Are there any situations where egg freezing might be available through the NHS, or is it always private?
Of course, of course. I mean, we are very proud. We have a very large fertility preservation clinic on the NHS. So the indication for NHS fertility preservation will be medical or surgical condition that could impair your fertility. For example, if someone has a lupus and need to have chemotherapy, we know that chemotherapy could sadly affect their egg reserve. So these patients could be referred fast track to us, and there will be funding for them. Obviously, patients with cancer, that goes without saying, who require radiotherapy to the pelvis or chemotherapy. But what's important, though, oncologists are getting much better at realizing that every person of reproductive age should really have opportunity to talk to a fertility specialist, even if they felt that there was not enough time, and even if they felt that they needed to start chemotherapy tomorrow. I think it's very crucial for every young person in the reproductive age to have the opportunity to have this consultation with fertility specialists. So there are other conditions, the surgical condition, for example, if someone had extremely severe endometriosis, they also could potentially have access to medical to NHS funding and the medical condition. Or if someone had even benign dermoid cyst, if someone lost already one ovary and there is another dermoid cyst in the second remaining ovaries, this put them at risk of losing second ovaries. That also will be important. And of course, we've been talking about eggs and females, but obviously male patients as well. The same applies to them if they're having chemotherapy or some intervention that can affect the reproductive tract. And also we have a very good access to patients who are going through gender dysphoria treatment, patients who are planning to have hormonal therapy. They are benign, but these patients also will have access to NHS funding. If it is just your life circumstances, we call it non-medical indication, sadly this will not be funded by NHS and in current practice.
Okay, thank you. So if we fast forward this, and we've now got someone that has previously frozen their eggs, what do they do when they've reached that point in their life and they've decided now they want to actually create a family? What does that look like for them?
Yeah, the good news to use the frozen eggs, it's much easier and simpler, and cost obviously is lower than the fresh stimulation. So you need to come back to us, or you could come back to us even if you had eggs frozen somewhere else. You can transfer your gametes between different clinics. We will see you again. We discuss all your history, what you are up to medically, surgically, socially, and in any aspects. And then it depends. So if you're coming back to us now with a spouse, if it's heterosexual couple, then we obviously can thaw the eggs and use the sperm of your partner to fertilize the eggs, and that process is pretty much straightforward. And then we just make sure we prepare your lining with very simple medication, and that doesn't necessarily involve injections. There are also options of almost natural cycle where we don't need to give you anything, and we just when you know you're ovulating, we thaw the eggs, fertilize them, create the embryos, and then you come for a very small procedure where you don't need to be put to sleep to put the embryo back. Of course, we have some group of patients who may find very difficult to have internal examination. We could put you to sleep if you had difficulties in speculum, the gynae examination. That's not a problem. We will look after you so you feel comfortable. But really, to use the eggs when they are already stored from your younger age will give you a massive advantage, because really, if for example you had your eggs frozen at the age of 30, we would say with approximately 15 eggs you will have at least 75% chance of a baby from all these eggs. So when it comes back to using them, we would recommend to thaw all of them, convert them to the embryos, then we would culture the embryos for a few days, and then by day 5 we will see which of these eggs turned into the best embryo. The good thing that if you had your eggs frozen very young, I hope that from 15 eggs you will have at least 3 or hopefully more than 3 very good looking embryos. So the process at that point will be to put one of them back to your womb, and you could refreeze this now embryos, the eggs converted into embryos. You could refreeze them safely and use them for the future if, for example, first transfer didn't work. If you're coming back as a same-sex couple, by the way, for same-sex couples, there is even more reason to consider freezing eggs at younger age, because if you know that you're going to need a donor in the future, it's good to have your eggs at a much younger age, because I always say the process is the same whether you're 40 or 30, and the cost is the same, but the outcome will be very, very different from you at 30 in comparison with 40. If you are still a single parent, and by that point you are absolutely ready to have a baby, as I said, it's also very common. You would need to use donor sperm. We will support you through all that thinking, logistic process, provide you with our implication counseling, just to explain about the legal aspects of donation in this country. And then also our counselors will have a very nice supportive session to think through, if you're a single parent, what to consider, what's your network, support network. And once all of that completed, then the process will be the same. Throwing the eggs, making sure you're lining at the right stage of development that we can either regulate by simple tablets, or, as I said before, could be sometimes even natural cycle, and then we would put in the embryo. Another, Sharon, very important point to make, some people ask or think that if unfortunately they develop menopause, then they won't be able to use the eggs and embryos. This is absolutely not correct. We are absolutely able to help patients to have baby with their previously frozen eggs and embryos, even if they develop menopause, because the whole of fertility preservation. So the lining we can support with artificial drugs. We can make your lining of the womb to grow, even if unfortunately the menopause took place. What we cannot artificially replace, it's your eggs.
Okay, yeah.
Yeah.
So if I decide to go down the donor route, what safeguards are in place for me in terms of, what screening happens to that donor sperm, for genetic conditions? Is there safeguards?
Yes, of course. I mean, I think this is a whole subject on its own. So, but yes, absolutely. So there are different approach how you could have treatment with donor gametes. So you could either have a non-donor, someone you actually bring to the clinic and they are assessed, or you could purchase, for example, sperm in the sperm bank of different, actually even international, not necessarily within one country, but from abroad as well. So any person who potentially wants to be a donor, they have to have absolutely very, very thorough medical assessment. Their history, family history is taken by their qualified specialist, with particular paying attention to if there were any congenital abnormalities, stillbirths, any losses in their family history. Then other factors of the social life are assessed. If they're young, or they have a higher risk of maybe sexually transmitted illnesses. So all donors are risk assessed from that perspective, and are also then they have a screen for sexually transmitted infection and different viruses, so hepatitis B, C, HIV, chlamydia, gonorrhea, HTLV virus. So there is a whole bunch of tests, syphilis, that we would assess anyone who potentially wants to be a donor. The donor should also be offered the supportive counseling and implication counseling, at least in the UK. So we can't vouch for everyone abroad, but they absolutely must have implication counseling, where we try to establish and understand, is it purely altruistic donation, so people just want to help others. then they also we have also there something called family limit. So if the donor donates and his, for example, sperm are used for different families, so in UK we have a limit to how many families this donor could donate, so that's around 10 families. However, not all countries have the restriction, and one may need to be aware that if they buy donor from international banks, though to use them in the UK, they need to comply with our regulation, but there is still possibility that they may donate to bigger numbers than 10. From genetic perspective, so the donor also offered some main important genetic screen like karyotype, cystic fibrosis. They're all checked for hemoglobinopathy, for example, sickle cell disease, thalassemia, and once we have all of this assessment, or if it's a bank that once they had all of this assessment, they would also freeze the gametes, and then they would need to be stored for a certain number of months. The donors would be asked to repeat again virology, and that's called quarantine, and only after that the gametes could be released for use. Another very common virus that all donors are tested is called cytomegalovirus, CMV. Is very prevalent in general population as well. So we usually, if you're a female patient who wants to take donor sperm, and the donor known to have antibodies for the virus CMV, that means that this donor been exposed in their life to this virus. It doesn't mean they have active virus now, but we would check yourself as well, because as I said, it's a very common virus. Many of us been exposed to it without realizing. So if you have also the same antibodies, then you can use a donor without any concern. If you've never been exposed to this virus, and there is a very theoretical risk that of infecting someone. But yes, so there is a very structured and very robust process of screening before donors could be used. However, doing genetic test cannot completely rule out every possible issue. Okay, so what could happen if the donor sperm was used by different families, and if for whatever reason there was a baby born with some issues at birth, sometimes the bank can restrict usage of the same donor, either because it was definitely confirmed that their newborn baby had problem due to genetic condition. Sometimes even they cannot say, even if there is no certain diagnosis it's related to genetics, but if it was quite significant issue, that again, as a precaution, the donor could be restricted. So that may influence, like if you bought several ampules of this donor and then this donor is restricted, then you may not be able to use these samples.
Okay, thank you very much. Could you help us understand what the success rates are like for single women compared to hetero couples embarking on a fertility journey?
Yes, guys, I mean, there is no really difference in outcome with IVF between different group of patients. Okay, so we know from multiple database, and for example, USA database are showing very strongly that whether someone has infertility, for example, for male factor or for tubal factor, any other factors, the actually chance of successful outcome will be mostly governed by the age and by the egg reserve. So it's all about the numbers and all about how young you are when we manage to get your eggs. So that applies to single parents as well. So it again will depend on your age and how many eggs we've got. Now, if someone wanted to look really, really deep inside and say, maybe because this population of patients doesn't have infertility, could it be that they might have some higher chance of success? Okay, so just a little bit of warning. At the moment, the egg freeze is getting more and more popular. A lot of people freezing eggs, but remember, it may take you another 10 years before you come to use these eggs. So actually, the global data on outcome from non-medical egg freeze is still quite limited. And we actually published as well from our guys' experience, and going to present again at BFS. So from you have roughly maybe so far 10% of people coming back to use these eggs. And I do believe that as time passing by, the number of people coming back will increase, because remember, it gives you some reproductive options that you may not even thought about it. It's not always to have one baby. It could be you froze your eggs at 30 and you had 2 or 3 babies, and then maybe at 42 you felt strongly you want to have another baby, whether you're within the same relationship or your relationship changed. Okay, so you could use these eggs from you younger to have another sibling for your baby. So it's not always just for one baby. So anyway, the main things that we still have on the global international level still slightly behind with data on outcome. So the numbers are still a bit lower to make big claims, but from data we have so far, it appears that using your frozen eggs, or if you are a single parent, give you comparable outcome to a couple who had some indication for fertility treatment, and really governed by your age and the numbers.
Okay, thank you very much. And finally, what one piece of advice would you give to a single woman who's just beginning to think about her fertility options?
I think what we see in our real world clinical practice, that of course it's a big step to finally say, okay, I want to go and talk to someone and assess myself. And what we see that unfortunately many people come quite late, where we unable to help. For example, some people come at 44 or 45. At that point, personally, doing any fertility treatment with your own eggs has such a small chance of successful outcome that almost one would say, is it a right thing to do? I mean, I think my important advice will be to try, if you were thinking it or not sure if it's for you, but try to have this consultation earlier rather than later, and have a chat with us. We will assess. For example, if you're 30 years old, you come and you have wonderful egg reserve and you're currently in a relationship that developed nicely, you may say, okay, hope to have baby in another year, and you may not need it, but equally I think the early we have this conversation and making decision, the better. And also, please, whatever you do in your life, but if you are teaching at schools, our schools are very good at teaching about contraception and worrying about teenage pregnancy.
Yeah.
But I think our society can do much better, because the contraceptive pills that we call family planning, remember the contraceptive pills can only help us not to get pregnant. And the problem that we think somehow that you can stop pills at 40 and it just happens naturally because you stopped pills. But I think we don't really explain that it's not the case. So the age is extremely important. So I think young girls and young generation needs to be well informed about our biology, physiology, and what options we have. And remember the society, the way we now develop, and it's amazing. Women doing so many things and develop their career, and it's very fascinating. And I'm pro women developing and having their career as well. But sadly, so we have social evolution. Biology is still the same.
Catching up.
So yeah, it can't catch up and will not catch up for hundreds of thousands of years. So I think their knowledge about the impact of age is really, really very, very important when you're considering your options. On the other hand, I would also warn people that freezing 10 or 15 or 20 eggs does not guarantee baby 100%. So the other thing I always say, look, if you were in the right circumstances to have a baby, please try to have baby as soon as it's feasible for you. Use these eggs as a backup, but don't just count on these 10 eggs, because there is a chance they may not give you a baby. And that kind of message that's also important.
Okay, thank you very much, and thank you for those that are listening. Can I just offer extended thanks again to Guidance St Thomas for allowing us access to Dr Julia, and if anybody's got any further questions, if you go on Guidance St Thomas website, you'll be able to contact them for further information. But a warm thank you again, Dr Julia. I know how busy you are, and it's been really good of you to come and talk us through fertility preservation and solo fertility journeys. So thank you.
Thank you. Thank you very much.